Good afternoon, and thank you for joining us. During this afternoon's webinar, we are going to be, hopefully, in an entertaining manner, delivering to you a webinar detailing the experiences that the University of Montreal Hospital had in optimizing its operating rooms using industrialization techniques and automation. My name is Joel Wambach. I'm a solution specialist with LOGI-D, and joining me is Christine Ouellette, who is the process specialist in hospital logistics at the University of Montreal Hospital. Very quickly going through an agenda of what we're going to discuss, we will discuss the industrialization of the supply chain or industrialized concepts. The project background, Christine will take us through the hospital and how the project came to be. We will then detail the actual steps involved in the project, the challenges that were encountered during the project, and some of the challenges that we're aware that have yet to come, the conditions that were put in place in order to make sure that the project was a success, and the benefits of the project itself. Why the supply chain? Why industrialize the supply chain? As you can see, in 1994, a study that was done by Chow and Heaver recognized that 46% of a hospital's operating budget was dedicated specifically towards logistics. And further to that, in 2009, the Healthcare Financial Management Association actually took that one step further and has actually realized that actually 55% of a hospital's overall spend budget is dedicated to supply chain costs. Traditionally, the healthcare market has slightly lagged behind the industrialized market, as you can see in areas such as first-time order accuracy, lines per order, inventory turns, charge capture and/or case costing, electronic data interchange. The healthcare or the clinical market versus the commodity market seems to be dragging a little bit behind, and therefore industrialization and automation concepts are beginning to be introduced and accepted by the healthcare industry. And why the OR? Well, typically you can see by the pie chart that over 65% of the costs are associated with these specialty areas, and specifically 45% of the supply costs across the departments are dedicated to the operating room. And further to that, you can see as the size of the hospital grows, you actually see the amount of inventory that grows. But what you can also see on the bottom is that the inventory turns in an operating room typically tend to trend below the average, specifically because of the nature of the inventory that is housed in the operating rooms.
Okay, let's take a look now at the project that was done. Before we get to project Opération, let's talk a bit about the CHUM, because I'm aware that most of you probably don't know who we are. Back in 1997, three hospitals merged to form CHUM, the University of Montreal Hospital Center. We have a total of about 1,000 beds, a little over 10,000 employees, 900 physicians. We are a teaching and research facility, so we have also a few hundred researchers and quite a few students that visit us every year. Between our three sites, we have 34 OR suites, with which we perform about 30,000 surgeries per year. And as you can see, the list of our main specialties, the biggest ones probably being cardiology, orthopedics, neurology. We are really looking forward towards a new building that should be completed by the year 2016. So as I said before, we're currently located on 3 sites. Our new building, with all the activities, will take place in this one single building. And as you can see, the research center and teaching facilities are going to be located right across the street. And also the image gives you an idea of the scale of this new hospital center. As you can see, one of our sites is going to be teared down completely, and it's rather small compared to what the new hospital is going to be. So we're since this new building, we will use the newest technologies and want to have optimized processes. So what we are doing today with Project Opération and other projects is really testing our future, testing the new processes that were chosen for this new hospital. Also, we've been working for the past few years on defining what supply chain means at CHUM. We've worked on defining our vision. We've written a mission statement. We've worked with our employees through Kaizen workshops to review our structure, to review our processes, implement KPIs, all of this to better satisfy our clients. By client, I mean our internal clients, so the different departments and services that focus on patients. So we want to free them from supply chain activities by taking care of those activities in order for them to be better served. Now let's get to the project. Back in 2009, what triggered the project was in a short period of time, the few staff that were involved in replenishment, inventory management at the OR level, they left without a transfer of knowledge. So quickly we had stockouts for some items, we had loads and loads of boxes for other items, so it was quite a problem. That's when the OR managers realized that our processes were manual, they were not standardized between the three sites, and we really needed to make a big review of those processes and implement new ones. So we created, or we listed our requirements. It's quite a big list, a long list. We wanted to have a better understanding of consumption. So we wanted to have statistics, data, something our ERP system did not provide us with the level of detail we wanted to have. We wanted to release clinical staff from the activities related to logistics and supply chain, and we wanted to provide new tools for materials management team that would take care of those activities for them to use optimized processes. We wanted to have a better overview of our consignment items because we were really dependent on our suppliers to provide us with information about the consignment items that were on our shelves. And last but not least, we wanted to make sure that case preparation was going to be done in a better way, optimized and better structured in order for us to capture cost about each case that was performed. Right from the start, we knew that we had to work in team. So not only the OR managers have been involved in the project from the beginning, but also sterilization and materials management. This morning we had our 70th meeting. We also have worked from the beginning with our IT department because the technology and software component of the project is a big one. We've counted on HR to help us with communication and change management. And also we relied on our technical services because phase one of the project needed for us to take out the old shelving system to put in place the new one. And of course, every step of the way, we've been working in collaboration with the LOGI-D team. Since we knew that the project would involve or impact a few hundred people and that it would last a few years, we created a slogan, an objective, and an image. So as you can see, the objective is really to optimize supply chain at the OR level, and our slogan is basically what supply chain optimization should be, which is to have the right product delivered at the right time, to the right place, by the right person.
So now that the project has been identified, that the areas or KPIs have been identified, it became time to actually begin to implement the Opération project. Essentially, the project was divided into four phases. The first phase and the second phase, which have been completed to date, included the implementation of the RFID-enabled Kanban replenishment system for general supplies, known as the 2-bin ID module. Phase 2 was the implementation of a system to manage and track all supplies that required item-level traceability. Lot numbers, serial numbers, and expiration dates as opposed to batch orders that would be performed with the 2-bin, and that module is known as CCID. Now, phase 3 revolved around the digitization, the computerization of the preference cards, the optimization of the case preparation, and also specifically the delegation of the case preparation to non-clinical staff and freeing up clinical staff clinical time to be able to spend more time with the patients. And phase 4, which is also currently underway, would be the optimization of the secondary storage locations, which would be those locations that were outside of the primary locations. In this case, it would be the actual operating theaters or suites themselves. Phase 1, which has been completed. The RFID-enabled Kanban system, or 2-bin ID, is a scenario where you take your standard quota and divide it by a set reorder point. And essentially what you're doing, if you follow along with the graph starting in the top left and working your way down to the bottom left, the demand detection. So when a reorder point is set, there is an RFID tag at the bin front, which is taken off of that bin front and placed onto an RFID antenna. That RFID antenna is connected to the IT network and is essentially acting as a pick list for those down in the supply staff, or materials management, so that they can essentially track their orders or know what the material requirements are of the OR in this case, without ever having to go to the locations or ever have to do any counting. Now, because you have, from a replenishment standpoint, because you have those two separate bins, the way the module works is that the supply staff will take the stock that is in the secondary location, rotate it forward as it has that built-in stock rotation feature, and replenish into the fresh stock into the secondary location and replace the RFID tag from the board right back onto the bin front, completing the cycle. In photographs, perhaps I'm a visual person, it makes it a little bit easier to see. In photograph 1, you see the clinical staff member actually looking for the supply. In slides 2 and in photographs 2 and 3, you can actually see picking the supplies, and there you see once that primary location is empty. In picture 4, you see the tag being removed, and in pictures 5 and 6, you see the tag being placed onto the RFID board. The entire cycle there takes anywhere between 6 and 9 seconds from actually picking the product to taking that tag and putting it on the board. And the study has been done that approximately 1 nurse per shift ends up actually taking a tag off of the bin front. Now, once the tags are on the board, as you can see in picture 1, what picture 2 is representing is the actual pick list that is being generated in picture 3. There in number 4, you can see the order actually being picked, and number 5, all of the orders being placed onto a transport cart for replenishment. Once replenishment occurs, the cart is delivered. The RFID tags are then scanned with the corresponding product that needs to be put away. As I had mentioned, you can see in picture 3, the stock is rotated from the secondary location into the primary to ensure that products are not sitting or resting at the back of a bin location. It has that built-in stock rotation feature again. In picture 5, you see replenishing into that secondary location, and 6, the RFID tag being placed onto the bin front, thus completing the cycle. Now you can see actual real live before and after pictures of the main storage room at the University of Montreal. Christine had mentioned there was a little bit of construction, there were a little bit of maneuvering, but as you can see, the organization, and I think that Christine would say that she's relatively happy with the result.
Yes.
Phase 2, moving on, was the implementation of managing supplies that required individual or item level traceability. What we referred to in phase 1 for the 2-bin ID project was for the general supplies. Now we're talking about things of high value, consignment items, or anything that requires lot number traceability, serial number traceability, or expiration traceability. And again, phase 2 has also been completed. Phase 2, or the CCID module, again, following the same workflow, upon receipt of the product needs to be conditioned. Essentially what that means is that we need to create a first level of traceability. So recognizing that it has been received by the hospital, and doing so, you're scanning the manufacturer's barcode on that product, and it's creating a unique RFID tag, which is corresponding all of the information about the product, the lot number, the serial number, and the expiration date, and tying it to a piece of information that is already keyed into the hospital's ERP. Upon put away of the product, the item itself, or the packaging, is wanted in front of an RFID board and then placed into its corresponding storage location, thus creating the second record of traceability. And consumption and replenishment is as simple as throwing the packaging into the RFID-enabled intelligent receptacle. As you can see, the conditioning process in photograph 1, the barcode is scanned. In photograph 2, the RFID label is created. In 3, it's actually placed onto the packaging, and in 4, the items are then placed into or are delivered essentially to the unit. Now, upon delivery, each one of those units is wanded quickly in front of that RFID board to create that second record of traceability, so you know that not only do you have it in your hospital, but you also know exactly where it's stored. And then obviously it's put away into its corresponding location. Upon consumption and replenishment, it's as simple as taking the item off of the shelf, opening it, taking it out of its packaging, and placing it onto the sterile field. And once the item has been consumed, the item is thrown into the garbage. Mm-hmm. Phase 3, which is currently underway, and that is the computerization of the preference cards, the optimization of the case preparation, and also the delegation of all case preparation to non-clinical staff members. Now, the before process, prior to Operaction actually being implemented, was a completely manual process. Involved Cardex cue cards that were manually written down. If there were ideas or new supplies that needed to be added, it was done so manually, if it was done at all, by the clinical staff. And there was absolutely no standardization, whether it came to the cards, the surgical schedule, and or the case cards. Now, how the digitization or computerization of the preference cards works is essentially a technician from the LOGI-D team works along with somebody from the clinical staff as they are actually picking a case. So they will simulate the case picking activities as one item is pulled. Using a portable RFID scanner, the RFID tag in front of the supply is taken, therefore creating a digital record of all of the supplies. Now, it should be noted that this was, in some cases, needed to be simulated. We're not going to be able to pick all 75,000 cases at once, but ultimately what you're able to do is get an actual digital representation of all of the preference cards. And you're automatically creating pick lists that can be used for further information data and data collection. The case picking activity is a three-step process that consists of various types of medical supplies, and we break it down into three relatively simplified areas: the picking of the predictable products, the picking of the unpredictable products, and the picking of the unpredictable products that occurred during the procedure. Predictable products are the products that are known prior to the procedure and represents about 80% of those items that are actually on that preference card. The unpredictable products would be those that are stored in the core or in that primary storage location that you know you need to add, but not necessarily know what size. Typically gloves would be a good example, that you know that you require them, but you need to add them to that case. And then the unpredictables would be your implantables and or your emergency products that are applied or added during the case. So the workflow is as such, where the preference card is printed off, and similar to the CCID module, an individual corresponding RFID tag is printed and affixed to the pick list or preference card. Now, the picking of the unpredictable products occurs in the sterilization department. The picking of the unpredictable products, as I had mentioned, occurs in the OR core, and the in-case consumption for the implantables and the emergency supplies, occurs inside the actual theater or suite itself. Where it really starts to take shape is during the return of the unused products and the software and system's ability to update the preference cards based on items that were not used during the case. As you can see here, this is a representation of the the pick list actually being created and the corresponding RFID tag being affixed to the pick list and preference card. In a manual scenario, essentially this would be the predictable supplies. As we had mentioned, the 80% of them where he's actually just going off of the paper-based pick list and checking off what supplies are being added to that case card. As you can see here, he's actually able to pick multiple cases at once. We do have the ability to offer optional voice picking, which essentially takes the pen and paper out of it completely, and using a series of checks and balances and further automating the process, thus reducing the possibility of human error, is actually able to pick all of the supplies hands-free using only a headset and a handheld RFID reader. The unpredictable products that are added just prior to the case, the RFID tag on that pick list is scanned, then the products are picked, and anything that is picked after the preference card or pick list has been scanned, the software is then going to update specifically what it was and when it was added to that particular pick list. Now, the in-case consumption for the implantables or the emergency projects is, again, is as simple as wanding the RFID-enabled preference card in front of the receptacle, which brings up all of the information about the supplies that have been picked for the case, and then anything that is thrown into the receptacle that has the RFID tag on it is then added to the list. Now, as I mentioned before, the unique feature about this, or particularly unique feature about this, is the return of those products that do not get used during that. Now, anything that is not used is taken along with that pick list and placed into a bag for return. Once it gets down to its department where the items are going to be returned, the same pick list is scanned, and then using the voice assisted, the headset, you're actually just reading off the manufacturer's, the last three numbers on a manufacturer's product code, and it's actually going to decrement a charge or an item from that pick list. Now, what this enables you to do is gather information about the pick list so that you can track historical usage of what was and what was not used, and thus automatically update your preference cards, or at least give you access to the right information to be able to make informed decisions. The management of the case picking activities, this is the new process that is currently in place, as I mentioned before, is the digitization of those cards and pick lists, the transmission of the actual surgical schedule itself, and the case preparation is now able to be performed by non-clinical personnel because that user-specific knowledge is no longer required, as it has been replaced with automation. The capture of the information of on products that is being added, the capture of the information of products that are not being added and being returned, but also specifically the management of those cost per case and the automatic updates or the automation of the possible updates to the preference cards and the pick list is currently now in place. Phase 4, which is currently underway, is the optimization of the secondary locations, not necessarily those in the core, but specifically in the SHUM's case, is actually within the OR suites themselves. Essentially, it's the same idea. It's the two-bin module, but these modules are being treated as their own locations as opposed to just carts or doors or areas, cubby holes, being just filled with products. So the same idea being utilized with the two-bin idea. You have the primary and the secondary location. The clinical staff, in this case, is placing the tags onto the RFID board. The information and the pick lists are being generated, but the actual replenishment occurs from the primary location and then into the secondary location. The replenishment of the OR theaters automates the order transmission. So again, nobody has to do a needs assessment of the suites themselves. The reduced risk of product contamination or product expiration. The replenishment is now occurring on a set schedule because you know exactly what you need, exactly where you need it, as opposed to any guesswork that has now been eliminated where somebody just goes arbitrarily because they think that a certain period of time has passed and that it's required. Mm-hmm. And the data now enables, not just in phase 4, but also in phase 1, 2, and 3, but the data that is being gathered by the software enables the hospital to set accurate par levels and quotas based on historical usage and not based on a just-in-case mentality by somebody suggesting that we just need to have as much of everything as possible on the shelves just in case it's required. Some actual photographs of the actual layouts of the theaters and suites themselves. And now the actual, it's interesting, but Christine would like to talk about the challenges that were met and also some challenges that are realized that are still to come.
As you can understand, there are many different dimensions to this project that it explains why it is taking quite a bit of time. We've started 2 years ago. We plan on finishing the project this year, by the end of this year, but we met quite a few challenges along the way, and we know that there are still some ahead of us. For phases 1, 2, and 4, one of the biggest challenge was to have a complete, reliable, up-to-date database. We needed to implement a new software. It had to be linked to the ERP system, but we needed to make sure we had the information about all the products that were stored in the OR, which was not an easy task to do. Even though we validated the information in the list of products with the people responsible at that time for inventory management on each site, during the implementation process, we found some surprises, some products that were there on the shelves that needed to stay there, but that weren't integrated in the database in the first place. The second challenge we met, and that is for all phases, was to make sure that we were working with the clinical staff during implementation for them to understand what we were doing, to be on board with the changes that were made. When we decided how the layouts of the primary storage areas, what they would be looking like, we wanted to make sure that the nurses knew what was put where, that they were on board, and it wasn't easy to do because as we know, nurses are not, it's not easy to access, to have time with them because they are in the suites. We know that nurses are already overloaded, they're working overtime, so it was a challenge for us to work with them during implementation so that afterwards they would be free from those activities. The collaboration between the departments, OR, materials management, and sterilization, it was new for them to work together, so that was also a challenge. And as I said, the physical layout, the new physical layout, it created quite a shock in the beginning, but now people are used to it and appreciate the new physical layout. As for phase 3, to go from a completely manual process, Cardex preference cards, to having the information within the LOGI-D software was a challenge. It takes a lot of time since the starting point was so bad. So again, we need to really work closely with the OR managers to make sure we have the head nurse to work with us to digitize the plick lists for afterwards to be able to delegate this activity, case preparation activity, to SPD. So you can see also we were working on changing the culture, make sure that the nurses understood that we were providing sterilization with new tools for the new staff to take charge of these activities and make sure they were confident that they would have the right products. And we've talked about products, but it's also instrumentation, of course, so products and instrumentation for each case that is performed. And we've come to the realization also that the different types of changes we were doing with phase 3, we haven't seen anywhere else. So for us at CHUM, as well as for LOGI-D, we were and we still are really in the R&D mode. So that takes time, but we need to continue with the objectives that we need to meet.
And just in reference to that, as we get into the winning conditions, and I know that we don't have a slide noting it, but I want to make, we had discussed this yesterday, is that just having the group in place, having the concept of a management team with KPIs, following those objectives really made a big difference in maintaining those success factors. Speaking of success factors for the new processes, the idea was to identify them, to make sure that we knew what we were looking for. It's the idea of if you want to get somewhere, you want to be able to at least follow a map and have a destination that even though there may be bumps along the road, ultimately you do know where you're going and staying on that straight road. Involving people on site during the planning and the implementation, that it's not just a question of introducing a new concept to somebody and expecting them to just embrace it immediately. You need to ensure that we're, and we do ensure, and we did ensure, that we're involving all of the parties involved, task forces, validation committees, planning committees, as you had mentioned. You've just had now your 70th planning committee meeting. So you're obviously doing a great job of communicating. And in reference to communicating, not just the project, but the project process, progress, the changes that may have occurred, technical information in some cases tends to fall better on some years than it does on others. So you have to make sure that you're maintaining a language that everybody is comfortable with. Using flow charts. I mentioned before, I'm a visual person, so being able to implement something, again, that is spoken in a universal language that everybody can be comfortable with. Establishing a plan and ensuring that it is followed. While obviously there's going to be some times where you do have to deviate slightly, the idea being is that there is one common goal. Progress reports, so that people can see that things are going well, that there are some, it is a bit of an arduous task, but ultimately when you see the progression, people realize that their efforts are being rewarded. And when I say being rewarded, we talk about planning recognitions activities, which was clarified to me are actually parties that are held at the hospital for success.
Yep.
Remaining focused on the objectives, regardless of the limitations or things that get into the ways. Ultimately, there was a significant ROI that was associated with the project, and not necessarily limiting to dollars or finances, but also work morale, workflows, making sure that clinical staff was spending more time with patients than the supply staff was spending more time on supplies. Yep. It was a phased approach, that it wasn't attempted to do everything at once, that while having a good plan in place makes it easier to layer the phases, but the idea that you're going to separate it into phases instead of just saying we're going to completely change the OR and we're going to do it today. And within any given phase you have to target a certain pilot specialties as well. Yeah. The benefits? Well, there's access to actual information now. A management report. As you can see, the picture there represents an actual dashboard that is proactively pushing information to anybody who has the LOGI data software installed on their computers. So they are actually going to be receiving information without having to search through a report, without having to look for Excel files or spreadsheets. They're actually going to be getting visual cues where there are going to be available opportunities. Replenishment optimization, making sure, as I had mentioned before, that the inventory levels are based on actual usage, but it also has a predictability feature where it recognizes seasonality and certain availability of certain products relevant to lead times. Fast and slow movers, making sure that if something has a relatively lengthy lead time, that you're not limiting yourself down to a smaller amount of stock. Tracking products about to expire, as we mentioned, anything that required traceability of lot numbers and serial numbers and expiration dates. The continuous optimization of the preference cards. In the same way that we're doing the optimization of the quotas, we're able to offer the information to the hospital and they can do make educated decisions as opposed to guesswork. And case costing. Being able to track the average cost per case, per procedure, per surgeon, and get actual exact surgery costs. Phase 1 and 2, the automated replenishment process. Clinical staff has been completely released from all of the replenishment activities that had been assigned to them before. And they're now being given statistical tools to analyze. Being able to access or to take raw data and have it translated into information that actions can be taken on is key within the process. The reduction of a user-dependent system and an expertise within one specific area, and being able to apply automation to make it such that not only is it easier, but it makes it for any individual, but that anybody at any given time can do. The example being somebody who is really good at their job, but has to go on vacation.
Yep.
It creates a bit of a lull. And in the SHUM's case, there was a lot of user independent knowledge, and when those resources were no longer available, it left the hospital in a little bit of a tricky situation.
Yep.
Space management. We didn't go into too much detail on the logistic flows, but also the use of the cubic footage within the actual OR space and the amount of floor space that was actually freed up by the tube-in ID system and its corresponding ISO high-density storage, and the better management of those costs associated with consignment and high-value products. From the case preparation in phase 3 and the digitization or computerization of the preference cards, clinical staff no longer picks cases. The process has been standardized across the board. They are now able to achieve accurate cost per case, and they're able to expand the role for those personnel who are non-clinical. I think that there might be we talk about taking tasks away from clinical, giving them the supply chain, but by automating a lot of those processes, what the hospital was actually able to do was take the non-clinical roles and expand those responsibilities even further. At this point, we've come to the conclusion of the webinar. I'm certain that everybody found it informative, if not entertaining, hopefully a little bit of both. With regards to questions, currently our website is open and available, and we have staff manning the website who are able to, as we speak, answer and receive and answer live in real time any question that you may have. On behalf of Christine Ouellette and myself, the SHUM and LOGI-D, I thank you very, very much for taking the time to be with us. We're supposed to have a note tab pad?
I don't know.
Do we high five and shake hands now?
Ja, this is it.
On est off là?
Oui.